No, these sessions are actually, you can say, rapid revision kind of sessions. So I'll be taking only the important and valuable points related to topics, right? So I'll be taking subjects in short sessions so that we can have a lot more sessions for a particular subject, and I'll just try to make sure that none of the important topics are missed, right? So in this particular session, I'll be keeping only 15 topics for orthopedics, and remaining important topics I'll keep in some other session, right? So starting the session with fracture clavicle, and it is one of the most commonest bone fractured in the body in all age groups, right, and all genders. So if someone asks you which bone is commonly fractured in a child or in adult, in male, female, or at birth, the answer has to be fracture clavicle, right? That is one thing. Now if you look at the x-ray, you can see this is the medial fragment, right, and this is the lateral fragment. So the usual site of fracture is the junction of medial 2/3 with lateral 1/3, right? So junction of medial 2/3 with lateral 1/3, right? Suppose if this is not in the option, then the second option which you need to remember is the lateral 1/3, right? So usually the option given is the junction of medial 2/3 and lateral 1/3, but in rare case, if that's not any of the option, then you can search for lateral 1/3. Now mechanism of injury in upper limb is mostly a foosh injury, that is fall on outstretched hand. Clear? So for most of the upper limb injuries, you can remember foosh, fall on outstretched hand. Clear? Now if you look at the displacements, the medial end is going upward and the lateral end is going downward, right? So medial fragment goes upward, that is because of pull of sternocleidomastoid, and the lateral fragment goes downward, this is because of pull of gravity or even deltoid, right? Now management is pretty simple. All you need to give is figure of 8, as you can see in the figure. So it is managed conservatively by figure of 8, right? So this is figure of 8 bandage, and very rarely if we feel that there are few complications, then we can go for ORIF. So in cases of complications, like if we feel that there are chances of injury to the nearby neurovascular structures, right? So rarely we go for ORIF, although, right? So this we do rarely. Now one of the good thing about this fracture is that it unites readily. So union is always the case, and very rarely we see cases of non-union, but most of the time the fracture unites very well, even if there is wide displacement. And most of the time we can see that the fracture has united in a slightly wrong position, and that is known as malunion, right? So the word malunion means actually union of a fracture in wrong position, but in case of fracture clavicle, it is of no concern to us, right? Hello Shanawaz bhai, hello, right? So actually the word mal means bad. So here the union, it has occurred in a bad position, but it is of no concern because it does not cause any functional disability. Namaskar Bhupendra bhai, right? So these points are enough for fracture clavicle, right? Then another important topic is dislocation of shoulder joint, and in the X-ray you can see this is the glenoid cavity here, and you can see that the head of humerus, now this is the head of humerus, it has gone anterior to the glenoid cavity. So this is anterior shoulder dislocation. Okay, so this is anterior shoulder dislocation, and amongst all the joints of the body, shoulder joint is the most common joint to dislocate, right? So it is the most common joint to dislocate, and if not managed properly, there are chances that it will dislocate again and again. So this is actually recurrent dislocation, and that's why we say that shoulder joint is not only the joint which dislocates commonly, it is the one which has this tendency to dislocate again and again. So recurrent dislocation is a common occurrence in the shoulder joint. And again, the mechanism of injury is a Fuchs injury, right? For upper limb, if you don't know the mechanism of injury, you can go with Fuchs injury, because that is the mechanism for majority of the injuries of upper limb. And here specifically, the shoulder joint is externally rotated, and that what pushes the head of humerus out of the glenoid cavity, right? Yes, Shanawaz bhai. And if you look here, this is the cricoid process. This is the coracoid process. I am extremely sorry. So this is the coracoid process here, and the head of humerus is below the coracoid process. So this type of dislocation is known as subcoracoid, because it is below the below the coracoid process. So this is subcoracoid. Clear? So if there is any question about the most common type of shoulder, then answer would be anterior. And if the question is about the most common subtype of anterior, then the answer has to be subcoracoid. I think most of you must be knowing the meaning of sub, that is below. Clear? So this is how the anterior shoulder dislocation looks like. This is the glenoid cavity, and this is the head of humerus. So it is moving anteriorly, and it is lying below the coracoid process. So this is the coracoid process. So we call it subcoracoid anterior dislocation. Now, sometimes what happens, the head of humerus moves below the glenoid cavity. So this we call subglenoid. Again, I think sub is clear to all of you, that is below. So in that case, the upper limb is abducted, and that is known as luxatio erecta, right? So this is known as luxatio erecta. Clear? And erecta, I think most of you must understand, almost straight. So the head is, the upper limb is abducted, and you can say the upper limb is, the arm region is just almost touching the ear. So that is luxatio erecta, and in that case, the head of the humerus is somewhere here, right? So somewhere here like this. So that is luxatio erecta. Now, rare type of dislocation is posterior dislocation of the shoulder joint, where the head of humerus goes behind, something like this, right? So this is the posterior dislocation. And for posterior dislocation, you have to remember only two conditions. One is epileptic fit, or the second one is electric shock. So if you have any question presentation which starts with the word or which includes actually any mention of epileptic fit or electrical shock, and it points towards dislocation of the shoulder, definitely the answer has to be posterior shoulder dislocation. Clear? And for posterior dislocation, shoulder dislocation, you have to remember one important radiological sign, and that is the electric bulb sign, right? So this is for posterior shoulder dislocation. Now there are certain clinical tests which we do for, yes, Shanawaz bhai, absolutely right. So electrical bulb or light bulb sign. Now there are certain clinical tests which you should remember. One is the Dugas test. Now normally what happens when there are movements at the shoulder joint, we can touch the tip of opposite shoulder with the fingers. But if there is shoulder dislocation, then touching the tip of opposite shoulder is not possible, and that is the Dugas test, right? Then another one is the Callaway's test, where because of the presence of the head of humerus within the axilla increases the vertical girth or the vertical circumference of the axilla. So this is the Callaway's test. And the third one is the Hamilton ruler test, because normally if we try to keep a ruler touching the lateral humeral epicondyle and the acromion process, it can never be in a straight line like this. But if there is shoulder dislocation, and it is easily possible to touch both the bony landmarks with a ruler kept in a straight line, right? So this is the Hamilton ruler test. So these are the three important clinical tests, of course theoretical, which you should know, and most of the times these has been framed in questions, right? Then management, every dislocation is an emergency. We have to relocate the shoulder, or that is known as reduction. So we have to reduce dislocation as early as possible. And for shoulder dislocation, we use one maneuver that is known as Cocker's maneuver, and the steps can be remembered by the mnemonic T, right? So T is for traction, then E is for external rotation, then A is for adduction, and M is for medial rotation. Clear? So just remember these steps, and this is actually the Cocker's maneuver. So traction, external rotation, adduction, and medial rotation. Yes, Shanavas bhai, this is Cocker's maneuver. Now complications. Since the axillary nerve is related to the surgical neck of humerus, so there might be a injury to the axillary nerve. So axillary nerve injury is a possibility, and as discussed previously, shoulder joint has this tendency to undergo dislocation again and again. So that is recurrent dislocation. So these are two important complications of shoulder dislocation. And if a patient is having recurrent shoulder dislocations, then there are certain changes which can be related to the glenoidal labrum as well as the head of humerus. So related to glenoidal labrum, there is the Bankert's lesion. Clear? So this is the Bankert's lesion, where there is tearing of the glenoidal labrum, right? So this is tearing of glenoidal labrum, and as the, very good Shanavas bhai, as the head of humerus moves anteriorly to the glenoid cavity, every time it strikes against the hard glenoid cavity, and that creates slight indentation fractures in the head of humerus, and those are known as Hill-Sachs lesion, right? So this is Hill-Sachs lesion. So just remember these two terms. Bankert's is related to glenoidal labrum, and those who oftenly who mix up, like Bankert's is related to which structure and hill sac is related to which structure. So you can remember humeral head H and hill sacs H. So you can remember H for H, and that will, will make sure that you don't do any sort of mistake, at least till the exam. So this is humeral head indentation fractures, right? So these are two terms which has to be perfect Shanavas by. So please remember these two terms. Then we move on to fracture supracondylar humerus, and the word supra is here, and I think most of you must understand what do you mean by the word supra. Supra is above. So the level of fracture is above the level of the humeral condyles. Now this is one entity which is only seen in children's. This is not seen in adults, right? So the supracondylar fracture is an entity limited to the childhood age, not seen in adults. Clear? Now there are two varieties depending on the movement of the distal fragment. If we see here, now this is the proximal fragment, clear, and this is the distal fragment. So there are two types based on the displacement of the distal fragment. So we have to look for the displacement of the distal fragment. Now here we can see that it is going behind or backward to the proximal fragment. So this type of variety is known as extension type. Clear? Suppose if it moved, it would have been moved forward towards somewhere here, then in such cases we would have called it flexion type, right? So this is the flexion variety. Out of the two, this is the most common and seen in the commonest one which is seen in the clinical practice. So most common type is the extension variety. And if I ask you what is extension, yes, Shanavas bhai, we will come to that. Just hold on for some time. So extension variety, here the distal fragment goes posteriorly, right? So just remember this much clearly, and this is seen in nearly 80% of cases. Now there is one 3-point bony relationship, and here the bony landmarks which are included in these 3 bony point relationship are the 2 condyles. So one is, you can say, medial condyle, right? Then on the other side is lateral condyle. Now these are of humerus, okay? So you can say this is humerus, and in the middle we have the olecranon process of ulna. Clear? So we always look for the relationship of these 3 landmarks when the elbow is flexed or extended. So suppose if the elbow is extended, they all will come in a straight line, and if there is any involvement of any of these 3 components, then this 3-point bony relationship will be distorted or disturbed. Now since here the fracture is occurring somewhere here, because this is the supracondylar region, right? So this is the supracondylar region and the fracture is occurring somewhere here. So it means that the bony relationship between these 3 components is not disturbed at all, and therefore what we will say, the 3-point bony relationship is maintained. Clear? Because the fracture line is not involving either of these 3 bony components. And needless to say, if there is any fracture of medial condyle or lateral condyle or fracture of dislocation of elbow, again this bony relationship will be damaged, will be disturbed, right? So in that case you will say that the 3-point bony relationship is disturbed, right? So I think this concept is quite easy if you know what are the three bony points which are considered in this concept, right? So here, since the fracture line is above, so it is not going to be disturbed at all, or in simpler words, we will say that the 3-point bony relationship is maintained. Now, if the fracture is displaced, obviously we will need to do reduction, and initially we try closed reduction, right? So initially we will try closed reduction, and then we can apply POP, and in case if it is not amenable to this closed reduction and POP application, obviously we have to go for open reduction. And this open reduction, once you do open reduction, you have to fix it with K wires. So we have to use small pointed stainless steel wires to hold the fragments together, right? So closed reduction plaster, or open reduction with K wires. Sometimes we can also try closed reduction with K wires under CM, right? Now, this fracture is very important in terms of its complications, because you have I think most of you must have already done PYQs, and you must have came across plenty of complications related question related to this fracture. So yes, obviously you are right, Shanawaz bhai. So this is brachial artery, right? And therefore, whenever you see a case of supracondylar humerus fracture, the very first thing you need to do is to check radial pulse. If radial pulse is coming nicely, you can feel it nicely, you can be very sure that brachial artery is not injured, right? And vice versa. And then another complication is Volkmann ischemia. So there is tendency of Volkmann ischemia, and this is ischemia of actually forearm muscles, especially flexor digitorum profundus, right, and flexor pollicis longus. And if this Volkmann's ischemia is not addressed timely, and this ischemia continues, later on the muscles will be replaced by fibrous tissues, and that condition is known as Volkmann ischemic contracture. Clear? So this is very important. This Volkmann's ischemia, this is also discussed under compartment syndrome. So sometimes you might have this word Volkmann's ischemia, or sometimes you might have the word compartment syndrome. The entity is actually same, and if the ischemia is not addressed over a period of time, the muscles will die and they will be replaced by a fibrous tissue, and that is known as VIC, that is Volkmann's ischemic contracture. And malunion is very commonly seen in this fracture. And again, I think most of you must understand what is malunion. This is union in bad position or wrong position, and this leads to gun stock deformity. Yes, so this is cubitus varus, and yes, it looks like gun stock. So these are very common questions, and I would request students to please remember this word varus here, and because we will be taking another entity where we will be discussing cubitus valgus. So most of the time students, they just mix up between the two terms. Now varus means that there is decrease in carrying angle. Clear? Cubitus varus, right? So there is decrease in carrying angle, right? So please remember this. Then sometimes there is possibility of formation of bony blocks, especially in the brachialis muscle, and that is known as myositis ossificans, right? So this is especially involving the brachialis muscle, and this is particularly seen if there is lot of manipulation in an attempt to reduce the fracture. So it is always said that don't manipulate too much, because that would lead to the possibility of myositis ossificans. And yes, there is involvement of median nerve, and more specifically one branch of median nerve, that is anterior interosseous nerve, right? So you can remember this sequence, and depending on the options you can mark your answer. If you get anterior interosseous nerve, mark it as the answer if there is no mention of anterior interosseous nerve, and if you get the parent median nerve, you can go for median nerve as well. So these are important points which you have to remember nicely, and most of the times the questions are pretty straightforward, and I expect all students to not to make any sort of suicidal errors, right? Then another entity is fracture lateral condyle of humerus. Now this is actually intra articular fracture. I think most of you must be knowing what is intra. Intra means inside, and articular word is joint. So the fracture line is extending till the joint, and therefore you have to make a proper reduction. So accuracy of reduction is very important here, and we write it as accurate reduction is very important. And because this is an epiphyseal area, so we have to make sure that it is not disturbed at all. So the management is open reduction plus fixation, that is internal fixation by K wires, right? So you can see here, this is the displaced fracture, right? And this one is actually the epiphysis. So you can see this is a metaphyseal area. So we have to reduce it, and then we can use K wires. Clear? Now you can see these K wires are curved because it just makes sure that there is no internal migration of the nails, and moreover it makes removal of these wires easy later on. So we need to do ORIF with K wires, and yes, this is the case here. Now what will happen if suppose if the child is not attending the medical facility well in time, and this side growth will be hampered, right? And the medial side will continue to grow normally. So what will happen over a period of time, there will be a valgus deformity, because there is no growth on the lateral aspect, but the medial epiphyseal area is working perfectly, so it will keep on growing, and therefore it will lead to outward deviation of the forearm, and this condition is known as cubitus valgus. And here the carrying angle will increase. So carrying angle is increased, right? So this is very important here. Most of the time I have seen students, they just mix up. So please remember L of valgus and L of lateral condyle, right? So remember L, and I'm very sure you will not mix up again, right? So valgus L and lateral condyle fracture humerus L there, right? So there is possibility of cubitus valgus deformity. Now what happens? The ulnar nerve is passing behind the medial condyle of humerus like this. This is ulnar nerve. So what will happen, as there will be a deformity in the form of cubitus valgus, it will lead to stretching of the ulnar nerve, and over a period of time, finally the ulnar nerve will also paralyzed, right? So this deformity will come after some period of time, and therefore ulnar nerve deformity will also be noticed after a certain period of time, and therefore we use the word tardy ulnar nerve palsy, right? So this is known as tardy ulnar nerve palsy. Now the word tardy means lazy or slow to come, and the word is, yes, of course, Shanavas bhai. So this is tardy ulnar nerve palsy, and the ulnar nerve injury is never seen in initial days of injury. Please remember that. It will be only seen if there is cubitus valgus, which of course comes after a certain period of time, and because of that deformity there is traction over the ulnar nerve as it is passing behind the medial condyle of humerus, right? So these are few words which you need to remember for lateral condyle of humerus fracture. And again, my special and request is, please remember the word valgus here, because this is always and always a key component in the questions, right? Then we come to fracture Colles. This is again a very important topic, and the fracture line is at the junction of cortical bone with cancellous bone, so we call it cortico cancellous junction, right, of the lower end of, and I think most of you must be knowing that it is a fracture of lower end of radius. And this is especially seen in elderly females, right? So especially seen in elderly females who are at risk of osteoporosis, postmenopausal, of course, because there is low level of estrogen, so that decreases the density of the bone, right? So elderly females. And normally what we see, if we compare the radial stelloid process with the ulnar stelloid process, it is the radial stelloid process which is at a lower level, right? So it is at a lower level than ulnar stelloid process, but because of fracture Colles, it migrates upward, and both the stelloid process almost lie at the same level. So radial stelloid process comes to lie at the same level or at a point slightly up above the ulnar stelloid process. So either at the same level or even above, right? So you can remember like this. Then the ulnar stelloid process. So this is how we can clinically get an idea whether it is fracture Colles or not. Now there are 6 characteristics deformity, and these are in 2 are in terms of the word dorsal, then 2 are in terms of lateral, right? And then one is supination, and the last one is impaction. So this is dorsal angulation, lateral angulation, right? I'm just trying to make sure that you remember it. So dorsal shift and lateral shift, right? So dorsal, lateral, angulation, shift, these are 4 deformities. Then supination and impaction. And why I am mentioning these deformities, because when we reduce it, we try to keep the wrist in the directions opposite to these the movement of the distal fragment, and therefore we keep the palm the wrist in palmar flexion and ulnar deviation. Sometimes you can also get the word medial deviation. So it is somewhat like handshake position, right? So these are the different displacements, and they are neutralized while reducing the fracture. So patient is managed by closed reduction plus POP slab followed by cast, right? And this is the handshaking position. There is palmar flexion and there is ulnar deviation. And yes, the characteristic deformity is the dinner fork deformity, right? So this much is enough for Colles fracture. And this here you can see this is actually dorsal, this is volar aspect, and you can see the distal fragment. This is the distal fragment actually, and it is, you can see the angulation and the displacement dorsally, right? So this is how you need to remember this, and it is quite easy to diagnose on X-ray. Then another important fracture is the fracture scaphoid, and it is the only carpal bone which can fracture and can undergo avascular necrosis. So, therefore, scaphoid is discussed too much because it has the tendency, especially the proximal fragment, to go into avascular necrosis. So, it is the proximal fragment which undergoes necrosis. Now, to understand the concept of why the proximal fragment undergoes necrosis, it's the peculiar blood supply. It goes in this manner, right? So this is distal, and this is the proximal part of scaphoid. And suppose if there is fracture anywhere here in the waist area, it is surely going to disrupt the blood supply, and therefore this fragment will undergo AVN, right? So therefore we discuss scaphoid a lot because it has a tendency to go into avascular necrosis. So most common site of fracture is through the waist, and clinically at times the x-ray may not show the fracture, so we have to rely on making a clinical diagnosis. And the landmark, I think most of you must be knowing, it is anatomical snuff box, right? So this is the area in which the patient comes with tenderness. So after a fush injury, if a patient presents with tenderness in the anatomical snuff box, and even if the fracture is not visualized on the x-ray, straight away you can take it as a fracture of scaphoid, and you have to manage it on the guidelines of fracture scaphoid, right? So that therefore we always discuss this anatomical snuff box, which is a triangular area which lies between the tendons of extensor pollicis longus, right? And on the other side there is extensor pollicis brevis and abductor pollicis longus. Clear? So this is a yes, Shanawaz bhai, you are absolutely right. So this is the limits of these of the anatomical snuff box. Now there is possibility that initial x-ray might not show you the fracture line, but this doesn't mean that there is no fracture at all. If you feel tenderness, if you can point out the tenderness in the anatomical snuff box post fush injury, straight away go for fracture scaphoid. The diagnosis has to be fracture scaphoid, right? And since at times the x-ray might not help you in making a diagnosis, so the diagnosis always has to be clinical. And x-ray might show fracture maybe around 10 to 14 days later when there is resorption along the fracture line, right? So we can take AP and lateral, but here we should include oblique view as well, right? So we can take a anterior-posterior, we can take a lateral view, and for especially for scaphoid, do include a oblique view as well. So for most of the fractures we take only two, AP and lateral, but for scaphoid this is an additional view which should be taken, right? And again you can take one more x-ray after 2 weeks, after 14 days, when there is resorption of the bone, and this might make the fracture line look more clearer, right? And if the fracture is not that displaced, you can apply a scaphoid cast, and this is applied in glass holding position. Clear? So this is the way in which the cast is applied, right? So here you can see the fracture line like this, right? So this is the part which might undergo AVN. So there is a possibility that this part might undergo avascular necrosis, right? Sometimes we might we can do ORIF with Herbert's screw as well, although this question has never been asked, just for your information. But do remember the glass holding position of cast application. So for this session I am just keeping these much topics only. We will take another session and we will continue the discussion part. So I'm very sure you might have enjoyed the session, so stay tuned. I'll come back with many more topics. So enough for the day. Thank you. Good night. God bless.